a 6-month-old boy with gastrointestinal bleeding and abdominal pain. Definition: your digestive or gastrointestinal tract includes the esophagus, stomach, small intestine, large intestine or colon, rectum, and anus. Bleeding can come from any of these areas. The amount of bleeding can be also so small that only a lab test can find it. Medical signs. Signs of bleeding in the upper digestive tract include bright red blood in vomit, vomit that looks like coffee grounds, black or tarry stool, dark blood mixed with stool, and signs of bleeding in the lower digestive tract include black or tarry stool, dark blood mixed with stool, and stool mixed or coated with bright red blood.
Upper GI bleeding is most likely when a patient presents with hematemesis, coffee ground emesis, or melena. Once upper GI bleed is suspected, hemodynamic stability must be assessed. Unstable patients with low blood pressure, tachycardia, or orthostatic changes should be immediately resuscitated. Assess ABCs. Insert 2 large bore IVs and give a bolus of 1 to 2 liters of normal saline and monitor continuously. Consider a rapid sequence intubation to prevent aspiration of blood with profuse hematemesis and altered mental status. If hypotension persists despite fluid boluses, transfuse with blood and correct coagulopathy. Intravenous proton pump inhibitors are started if suspected peptic ulcer disease. IV octreotide is used for varicose bleeds. Peptic ulcer disease is the most common cause of upper GI bleeding. Think about PUD in a patient with epigastric discomfort and a history of NSAIDs use. Think about varicose bleeds in a patient with portal hypertension and stigmata of chronic liver disease. A history of vomiting, retching, followed by hematemesis suggests Mallory-Weiss tear. Patients with acute abdomen and signs of peritonitis should be imaged to rule out perforation, along with prompt surgical consultation. Suspect aortoenteric fistula with a history of aortic graft. as emergency endoscopy is indicated and surgery if diagnosed. With appropriate resuscitation, 80% of upper GI bleeds will stop spontaneously. Variceal bleeds, however, have the highest mortality rate and oral endoscopic banding is recommended.
Etiology: Neonates. Anal fissures are the most common cause of gastrointestinal bleeding in infants. Typically, red blood streaks stool or causes a spot of blood in the diaper. The cause is a tear at the mucinous line, most commonly located dorsally in the midline. Other common causes of apparent neonatal gastrointestinal bleeds include bacterial enteritis, milk protein, allergies, intussusceptions, swallow maternal blood, and bipolar hyperplasia. Statistics. In the pediatric ICU populations, 6 to 20% of the general pediatric population has upper gastrointestinal bleeds. The incidence of lower gastrointestinal bleeding has not been well established. In one report, rectal bleeding alone accounted for 0.3% of the chief complaint is more than 40,000 patients presented to a major urban emergency department. An investigation into the epidemiology of gastrointestinal bleeding in the hospital children in the United States report that there were 23,383 pediatric discharges with a diagnosis of gastrointestinal bleeding, accounting for 0.5% of all discharges. Abdominal pain.
So if you have abdominal pain, trying to treat it and trying to prevent it are very difficult questions to ask. So it's important to understand where the pain's coming from in order to treat it, in order to prevent it. So if you're having pain, say, in the right upper quadrant that may be going up to your shoulder and it's more of a cramping pain, that could be gallbladder disease or gallstone or something of that region. It'd be important to see your doctor because they may order some tests to take a look at your gallbladder to see if the gallbladder is inflamed or if there's a stone that's stuck in the duct or some sort of abnormality there. If you're having epigastric pain and that's associated with heartburn or pain after eating, you may have gastritis or peptic ulcer or something of that region, and the doctor may ask you to see a gastroenterologist to do an endoscopy to take a look inside your stomach to see if you have an ulcer. If you have right lower quadrant pain, the most common cause of pain in that area is appendicitis. So you may have to go to the doctor to have that evaluated to make sure you don't have appendicitis. If you do, that's considered a medical and surgical emergency. Your doctor may order a CAT scan in order to take a look at that region of your digestive tract and order the appropriate tests. And if surgery is required for the appendix, he'll call a surgeon to do an appendectomy. Again, if you have pain on the left lower quadrant, again, diverticular pain or diverticulitis is probably one of the most common causes of pain in that region. Again, the doctor may order some tests or a CT scan in order to investigate that. Now, based on their investigation and the tests that they order, they'll recommend different therapies, and depending on the cause, they're going to have special medications such as antibiotics, or if it's a surgical abdomen, you'll have to be referred to a surgeon to have surgery done. So it's a very difficult question to ask, but understanding where the pain is coming from helps to manage it.
Conclusions. A complete history can often identify a preoperative gastrointestinal bleeding source and direct an existing workup. For example, MEC in most units is diagnosis basis of history and clinical presentation, has age and etiology specific questions, as about acuteness or chronicity of bleeding, color and quantity of the blood, in stir or hemolysis, antecedent sign of or history of straining, abdominal pain, and trauma. Thank you.